Morning, everybody. Thank you so much for joining us today. We're very happy that you could join us. It's a lovely spring-like weather happening here in Ontario across many regions. And today we are looking at the level of care utilization system tool, and happy to have you here with us. I will be starting today's session with a land acknowledgement, as it is one way for us to respond to one of the many calls to action in the Truth and Reconciliation Commission report. Starting our meetings in this way encourages us to remember the historical and ongoing impact of colonization of Indigenous people as we make decisions on behalf of our organizations that will impact the people accessing our services, so that our decisions may always move us and our work towards reconciliation and healing relationships with Indigenous nations, people, and the land. Because we are in a virtual space today and participants are from across the region, I will start by locating myself and acknowledging the land that I'm joining from. I am a white cisgendered settler, and I am located on traditional lands of the Anishinaabe peoples in the Robinson, Huron, and Williams Treaties areas. I wish to recognize the long history of First Nations and Métis people in Ontario and show respect to them today. I would also like to acknowledge the neighboring communities of Nipissing First Nation and Dokis First Nation. This land is currently known as North Bay. I would like to acknowledge all those who are present stewards of this land. Colonialism does not exist in a past tense or historical context. Colonialism is a current ongoing process, and as such, I will continue to acknowledge the disproportionate harms Indigenous peoples experience due to mental health challenges and substance use as a direct result of colonization, and that colonialism and racism continue to influence social structures such as drug laws, the legal system, child welfare, and healthcare, including mental health and addiction services. Personally, I've taken steps to learn more about those disproportionate harms to Indigenous peoples in my own community and continue to have conversations with my children about my own learnings. I think about how we can make our system better, improve access, and understand inequity and the historical ongoing impact of colonization. I have hope that in each of these actions and steps that I take personally will help us move toward reconciliation and healing. So this is our fifth in a series of 6 offerings. It is a jam-packed webinar, and what we are hoping is that participants will have an opportunity to ask questions via the chat box. So you'll notice at the bottom there is a chat box that you can open up and type in your messages. We will do our best to answer your questions during the session. And if we do not have the opportunity to get to your question, we will either bring it to the workshop that's coming up on February the 23rd, or we will provide a written answer to participants in an email following. So just to ground us in today, this series was a building off of the 2020 series that we did. And the objective of this series is to increase the confidence in use and uptake of those standardized tools and the associated data for decision-making in the mental health and addiction sector. These sessions are open to everyone, so all levels of the organization and of the system are welcome to attend these. This is, again, going to be a lot of information, and it will feel likely for some of you like you're drinking from a fire hose. It can feel overwhelming. But we are really hoping that there'll be some nuggets for you that you take out of this session. The first 2 standardized tools that we highlighted were the Ontario Perception of Care tool and the Ontario Common Assessment of Need tool, which brings us today, the LOCUS. And so without further delay, I would like to introduce our speaker and subject matter expert for today's session. Dr. Ken Minkoff is a board-certified community psychiatrist and addiction psychiatrist, who is the VP of Zia Partners, Inc., a behavioral health system consultation firm in Arizona that specializes in system transformation, integrated systems, and crisis systems, and has done extensive work in Canada. He is a board member of the American Association for Community Psychiatry and was one of the original and ongoing developers of LOCUS, as well a contributor to the American Society of Addiction Medicine criteria for substance use disorder services. So Dr. Minkoff, I will now share the screens, all yours.
Well, thank you, Laura, and welcome everybody to the fire hose, as it were. When we planned the webinar, we asked participants to share some background about their experience with LOCUS. And we discovered that while some of you have been using LOCUS for a while in various forms and methods, some on paper, some electronically, most of the participants had heard of LOCUS, but were not actually using it. So we've designed this webinar to provide some information that should make this more understandable for non-users, as well as helping those of you who are already involved to be connecting what you're doing to opportunities for using LOCUS data for quality improvement purposes in a variety of ways. Subsequent to the webinar, we will be giving, we're not going to be showing the LOCUS, so if you've never seen it, you won't see it now, but we will be sharing a kind of demonstration of the tool later, as well as anyone who wants more information about how to license the tool and use the tool and get connected to electronic scoring. If you're not connected to that, we will be providing that information after the fact. So the starting place for LOCUS, LOCUS was developed 25 years ago. I was part of the initial development of the tool, and it's continuing to grow and expand. And the framework for LOCUS, or level of care utilization system, is that it's moving everyone in the direction of a national standard or international standard for what we call service intensity assessment and planning for mental health care. So, so what is service intensity assessment and planning? Service intensity assessment and planning is a clinically informed process of determining the correct amount and combination of the various types of services and supports that best address an individual's needs at a given point in time. So it's not about matching diagnosis to intervention. It's about the quantity, frequency, and intensity of services that an individual needs at a particular moment. And it therefore is a dimension of assessment that's orthogonal, or an independent dimension of assessment that intersects with other kinds of assessments that one does. Diagnostic assessments, broad categories of needs assessment, whatever it is that you've identified that you're trying to help somebody with, service intensity assessment is a way of helping you understand how much of it they need. Okay, so the components of doing a standardized service intensity assessment and planning involve a structured method of assessing an individual's needs, risks, strengths, stress, and support at a given point in time. And mapping that into a continuum of service intensities, which are roughly defined as levels of care, although they're more complex than that, which involve the type of setting. Are they in the home? Are they in a residential setting? Are they in a hospital setting? The intensity and type of staffing, how many staff, how many medical staff, nursing staff, how frequently are they in contact with those staff? How much care coordination and case management are they receiving? How much programming is provided, and so forth. and a crosswalk to match the assessed needs, strengths, et cetera, to the specific level and combination of service intensities. So the best practice for doing this has been developed over decades. And I've been involved in both the mental health side of this and the addiction side of this, and we continue to improve our ability to do this. So there's, you guys may be familiar with the American Society of Addiction Medicine, ASAB, patient placement criteria for people receiving substance use disorder treatment. And now we have the LOCUS family of tools for mental health services. The LOCUS specifically within that family is designed for adults, and then there are other tools for children and for infants. And the elements of these include that the service intensity assessment is a component of a comprehensive clinical assessment, and should not be, and many systems are, be driven by the needs primarily of a payer to conserve resources. It's a way of identifying actual resource needs based on the clinical needs of the person. And one of the advantages of doing it is it allows you to identify resource gaps when you have folks with identified levels of need that may not be able to be met. Nonetheless, you can document that those needs are there. In addition, the service intensity assessment requires an analysis of independent but interactive variables. It's a multi-dimensional assessment, okay? And it's transdiagnostic. That means, as I said, the service intensity is not about what your diagnosis is. It's independent of that, and the same service intensity dimensions are needed regardless of what diagnosis or combination of diagnoses the person is presenting with. And it's flexible because it needs to be able to change over time. For some people, that happens quickly in a crisis. For other individuals, it's more stable over the long term. One of the things that has launched this, so you guys are probably not aware of this in Canada, but there was a big insurance decision in the United States. And one of the outcomes of that decision was that the federal judge stated that the LOCUS and the LOCUS family of tools and the ASAM tools were regarded as, quote, national standards for doing service intensity assessments, which is a big deal because in the US, a lot of insurance companies have their own proprietary tools. And this allows us to get past that into creating a common language that is of value either in the US or in Canada for some of the reasons I'll be talking about. So, the advantage of having this kind of common language, no matter where you are, is not only just to give individual staff a tool to help figure this out. It allows, as we'll be talking about, and this is why this is so relevant for the CMHA E-QIP project, it allows for having shared data for continuous quality improvement, of the ability to have people receiving the right service intensity at the right place and the right time, and to design systems that allocate resources accordingly. So it allows you to use a standard language for determining needs and then help move clinicians in general to have inter-rater reliability in their service intensity determinations. Very basically, it helps to say, if we have two clinicians evaluating a client, we don't want one of them to do an assessment that says this person needs residential services and someone else saying they don't. They just argue about who's right. Using a standard tool helps you to generate data that helps you to determine what level of intensity that person needs. In addition, It allows for the identification of gaps. So this person or this cohort of people are identified as needing residential services, but they're not available. Well, now we can do service planning because a gap has been identified, and we can see whether the available resources within our system are properly allocated. We may have more residential services than we need based on the assessment of needs of the people and so forth. So the idea of this framework is to have a common language that can provide a clear understanding to persons served and their families about how service intensity decisions are being made objectively and quantifiably, to the individual clinicians or provider organizations who are often the ones making these determinations and then designing their own resource allocations for the populations for which they are responsible, and payers and regional or provincial population health managers as well. So this is what the LOCUS and the LOCUS family of tools are designed to do. And there are two basic use levels. Some of you who are using the tool are using for both. Some are using mostly for one or the other. But one use level is for acute crisis. A person is presenting in an acute situation. They're having suicidal thoughts, for example. They're hearing voices. What level of care do they need in order to be safe and receive the most effective treatment in the moment? Do they need hospitalization? Do they need a crisis bed? Do they need intensive outpatient intervention? Do they need routine outpatient intervention, et cetera? And then the other is for ongoing population management. So you have a cohort of individuals with mental health needs, and you're trying to see how many of them need an assertive community treatment team, how many of them need a residential service, how many of them need intensive case management, routine outpatient, and so on, over an extended period of time, looking at their baseline functioning over a period of 3 to 6 months or a year or so forth. The LOCUS can be used for either of those use cases, which is very helpful because you can use one tool for both things as part of this common language. Okay. Okay, so the quality improvement opportunities that emerge from using the LOCUS, this slide helps us to organize our thinking. And when we get into the workshop, we're hoping that you guys will be bringing your own questions or challenges. Here are some of the use cases that I'm thinking of using LOCUS data to help improve. And so we can dig into the details. Some of you we know have already planned to come to the workshop with your data or questions or examples. Some of you may still be thinking about it, and hopefully this will give you some ideas, and we welcome any of your thoughts and questions about things you might want to bring into the subsequent workshop, including whether you're not a LOCUS user and you want to learn more about how that's going and so forth. But so here are some of the data quality improvement questions you can ask when you are able to gather individual and collective LOCUS data, which is ideally done through some sort of electronic software package that allows you to aggregate your data and also assess not only what the client data is, but allows you to flag mismatches, which is something that the Deerfield software system can do for you. So for clients, are individual clients or cohorts of clients currently receiving the right, quote unquote, service intensity or level of care? For staff, how consistent or effective are staff in making accurate level of care decisions, acute or ongoing? And how do we build inter-rater reliability? For programs, are the clients our program is generally serving in the right level of care currently? How can we monitor and improve transitions? Can we help determine better timing of transitions? Can we help facilitate getting people who are mismatched into the right level over time. For agencies, how well do we map available services to client needs? Do we have the right, for the clients that we're sharing, if they're at various locus levels, do our service array or the service array of our partners match the levels of need in our system, or are they designed in a way that's mismatched? And what can we do about it? To the extent that we manage utilization by having an oversight process where we determine whether clients are receiving the right service intensities, how can those utilization managers work in partnership with clinicians and programs to have a common language and help continuously improve the ability of getting people into the right services at the right time, and for both acute and ongoing services. And then for those folks, small number of folks in the audience who are regional or provincial health planners, clearly using this data in an aggregate way across a larger population can help you with both current and future resource planning, and help your utilization managers be more effective in working using clinically driven service intensity assessment data to plan appropriately for population needs. And help facilitate transitions of care and resource allocations across the region that you're managing. So this is the framework, and this is of course why CMHA has brought the tools to your attention. Because there is no other set of tools that uniquely focuses on the service intensity process, which is critically important in helping people, make progress toward recovery. So I want to dig into exactly how the LOCUS tool itself works and related to the general discussion that I just provided. So the LOCUS tool is actually a very simple tool. It has 6 dimensions within which you do a rating. The rating in each dimension is a number. Okay, and then the collective ratings in those 6 dimensions connect to recommending a service intensity. There are 6 service intensity levels that get mapped to, and it really is, of all the things that you'll ever use as a tool, remarkably simple and straightforward. Okay, and there is there's a scoring algorithm that helps to provide different weighting to different scores in different dimensions. If you've ever seen a written locus, the algorithm is kind of on paper. It looks like a complicated wiring diagram, and you can learn to do it by paper, but we really recommend you use the electronic scoring algorithm provided by Deerfield because it's much more reliable to the fidelity of the tool. And it helps to avoid unintended errors in the recommendation system, which can sometimes happen when you're just adding the scores or trying to do it by hand. I'm going to tell you more about the dimensions and so forth. So the 6 dimensions are risk of harm. In other words, what's the level of significant risk that this person will cause serious harm to themselves or someone else in the immediate time frame. The second dimension is called functional status, which relates to the person's basic ability to take care of themselves, manage themselves in the environment, perform basic functional tasks of daily living, and so forth. The third dimension, which is called co-occurring conditions, relates to, if you have a presenting issue for you guys in a mental health issue, to what extent is co-occurring substance use, co-occurring physical, co-occurring developmental issues, affect the service intensity needs of that individual's based on their presentation for their mental health issues. The fourth dimension is what we call recovery environment. It has two sub-dimensions. One is the level of stress in the environment, and then there's the level of support in the environment. And higher levels of support can promote the need for lower levels of care, and higher levels of stress promote the need for higher levels of care, usually. The fifth dimension is called treatment and recovery history, which helps you look at how effective have previous efforts been to be helpful. And the more that's so, the less ongoing need is likely to be present. Okay, the more quickly we can hope the person will be resolved, the situation will be resolved over time. And the final one is the level of engagement and recovery, which is how engaged in the treatment process is the person. Obviously, the more engaged people are, the more motivated they are to do the work, the more likely they are to be successful in a lower level of care than if they're not so motivated. So, so these are the six dimensions. Each one, as I said, is scored from 1 to 5. And you know, that gives you a sense of where things are and how easy it is to use the tool. Okay. So as I said, here each of the service intensity levels gets scored 1 to 5, ranging from lowest to highest levels of service intensity. Each dimension, the way the tool works, is for each score, there are 4 to 6 anchor points, little sentences. And then you go through the tool and you pick the sentences that, and it's good to pick all the ones that you think match the person. And then you find the place where you found the highest rating, the most risk, as it were, and you use that as your ultimate score. Okay. And then you add them all up to create what's called a composite score, and then you use the algorithm to get the ultimate result. So you're actually picking 7 numbers, 1 for each score, and then 2, 1 for stress, 1 for support. And so the final service intensity recommendation is derived from the composite sum and the application of the scoring algorithm. The sum alone does not produce reliable results. And independent criteria for some dimensions drive the final intensity score regardless of the composite score. And, you know, so there's a computer-assisted algorithm through Deerfield that helps the reliability in the scoring. So, and here are the levels of care. And level of care is kind of an oversimplified term. And what we try to advocate for is thinking of these as bundles of service intensities, because as you go higher in the levels, there are various ways of packaging up services within that quote unquote level. And individuals may be at the same level, but have very different service package needs. That's determined by, you know, their clinical, the broader nature of their clinical assessment. And so you're kind of challenged to be looking at a level as being an amount of and type of service in the bundle. So let me go through this. Recovery, maintenance, and health management, level 1, is kind of the generic availability of health, wellness, and support services, having access to crisis services, whatever it is that you need for anybody in the community. Okay, level 2, low intensity community-based services, and recovery, maintenance, health management for some people can be kind of a step down from higher levels where they're just completely stable and all they do is get sort of basic care, you know, every few months. But that's about it. Low intensity community-based services is a fancy jargony way of saying routine outpatient services. Okay, and within that, there's a level of care coordination and access to medical and therapy care and so forth. High intensity community-based services is a level 3, and it's kind of like intensive outpatient services or an intensive case management team. Level 4, medically monitored non-residential services, has various forms, one of which can be an assertive community treatment team. Another version of this would be partial hospitalization. So you can have 2 people at level 4 who, one, the person who's going to go to a partial hospital may not be able to manage ACT and vice versa. But both of those are level 4, high intensity, medically monitored community-based services. Level 5 is medically monitored 24-hour residential services, an acute crisis residential stay, a longer-term rehabilitation treatment facility. Those can be level 5 services. And level 6, medically managed secure residential services, in most places refer to hospitalization, although you can create similar things that are not called hospitals, but have all the same qualities of a medically managed secure residential. So it's actually not a very complicated matching. But so you score on the dimensions, 7 numbers. They algorithm into a recommendation for a level. You look within the level, each level has a description of the kinds of services that can be packaged or bundled together. And it gives you a very simple set of data that you can use to kind of look at individual needs as well as mapping for a cohort or a population, agency, region, province, etc. So, so within each level, this is what I was talking about earlier. It's a little jargony in the slide. But what it says is that at each level, you have options. You have individual therapy, counseling, families, groups, medical care, nursing care, peer support. And all of those things are available potentially at any level. And at the higher levels, you get the access to, 24-hour housing support, for example. But you have to package them together. It's how much of these and what's the combination of these and what's the frequency of these and the intensity of these and the level of medical and nursing support that's needed for this particular individual. So within each level, you get to put together a package that makes sense, that meets the sort of minimum service intensity requirements that are defined by that level. Within this, you can create a frame for having a more or less seamless continuum of services through which people can move over time as hopefully they progress toward recovery, as well as having access to higher levels of care for those times when they're doing, having more challenges and need more help and support to be safe and stable and make further progress. So just to be thinking again about the different things that comprise service intensity. Okay, so we have a setting: secure residential, open residential, ambulatory, school, home, and community-based services. Medical involvement, daily medical management, weekly monitoring, no medical supervision at all. Nursing involvement, 24-hour skilled nursing as in a hospital, nursing available 1 shift a day, nursing on call, no nursing available. Staffing, formal services, informal peer support, formal primary care, care coordination, service array, what kinds of services are available, individual, group, family, case management, and the frequency and length of contact. Okay. So this tool helps you to figure out how to make those decisions about bundling those various aspects for individuals who may have exactly the same diagnosis or diagnoses, right? You may have 5 different people in your agency with schizophrenia, and they may all have some level of co-occurring substance use as an issue for them. But they may all, based on where they are in their lives at the moment, based on their LOCUS scores, each of them would be appropriate for some different level of service intensity. And that's the beauty of the tool. It gives you a simple common language and an easy way to figure that out. Now, what LOCUS will not do is it won't tell you what medication to prescribe. It doesn't give you an exact staffing pattern for each program. That gives you a general thing to apply within your own world. It doesn't tell you whether people will need ECT. So once you figure the service intensity level out, you have to put the whole package together along with what the person's needs and needs are, but also what their preferences are to help find the best match for that individual. Okay, but it gives you a clinical, objective, scored framework within which to do so. Now, in order to use the LOCUS, training is really important. And over the last several decades, we have worked at the American Association of Community Psychiatry, which is kind of the owner of this tool. We created it, it's ours, we're responsible for it, we're held accountable for its proper use. We've learned that proper training is essential to optimize reliability and validity. We are in the process of releasing an asynchronous training that we have developed for the LOCUS. That'll be out in the next few months. Currently, there's a training that we have sponsored through Deerfield that people can get. It's kind of a live online thing, but we're creating an asynchronous one. But it's important for everybody to, first of all, receive the same training. So it's somewhat standardized. And then we're also working to reinforce the importance of having on-site supervisors who become LOCUS coaches or LOCUS leaders, as we call them. And there's a clear need for continuous improvement just around issues of inter-rater reliability in the scoring so that people don't drift. And to make sure that people are actually using the tool based on the clinical presentation of the individual, not contorting the result to so that it comes up with the answer they were hoping for in the first place. And so that, that requires some work. And then for the other tools, our partner, the children's tools, we partner with the American Academy of Child and Adolescent Psychiatry to create those tools, and they do the training and so forth and so on. So that's why we call it the LOCUS family of tools. And yeah, and you can see on that slide, there was a link where you could go ahead and get more information about training. And then we have this whole package of additional materials. Now, some of you may not be connected to this. Stephanie Smith-Dillard, who's our full-time projects operations coordinator for the AACP, is responsible for all of the LOCUS details. She's on the webinar. And we will be following up with links and things so you can get more information, guides for service users, explanations for families, manuals, case examples to use for training and all that kind of stuff that we're putting together. And we have we're in the continuous process of improving the tool. We're expecting to have a new updated version out in 2024. Just based on constant feedback from users about how to make it better. Now, getting back to the data, just to remind everybody why we're here. Some of you who are not using the LOCUS, you may say, well, we're not interested in quality improvement, no matter what CMHA says, but But this tool may be useful for us just practically day to day, because it doesn't take much time to do. Experienced users, once they get to know the person, as part of their regular assessment, they can use the LOCUS and come up with the ratings in 5 to 10 minutes. It's very quick. But there are so many opportunities for the standardized data to be used for quality improvement that that's the focus of this discussion. And when you have computerized software rather than paper, you have natural aggregation of the data. And as I said earlier, the scoring allows you to mark recommended placement from the tool and actual placement from the tool. So your computerized scoring algorithm and the whole mechanism allows you to actually track mismatches. And then when you do it sequentially, you also can get flow to see the degree to which people are moving from one level to the next level and all of that kind of stuff. So the data can look at actual placement versus recommended placement. They can look at which dimensional scores in your world are contributing to higher or lower placement and how they can be modified. In other words, you have an absence of support for your group, and maybe if you figure out how to enhance family support by providing more support in the context, more people would be able to manage at lower levels of care, as it were. Looking at times when something was recommended that literally was unavailable, and what was the unavailability due to? Is it lack of resources is one, but it also could be that some of your available resources have admission criteria that don't make any sense. So they're designed not to take the people that need to be in that. And you can deal with that as a systemic quality improvement issue. Why are, we have all these people assessed as needing level 5. We have a level 5 service, but they keep refusing admissions. What's going on here? When you look at aggregate data, then you can look at this across a whole agency, a whole community, a whole region, a whole, or a whole province. Okay, so that's where the data comes from. We're looking forward in the workshop to digging into details about the data you have, the data you would like to create. How do we structure this? What do we do? It's open season in the workshop on the 23rd. For you to bring whatever questions you have. And if you send them in advance, if you haven't done that already, that's really helpful because it allows us to plan accordingly. I can plan the time to make sure that all the questions that are raised ahead of time are addressed somewhere during the time. So whereas if you wait till you're there to bring them up, it's a little more risky as to whether we'll be planning to incorporate them into the discussion. We may get off track. So please send us stuff in advance. It's so much more helpful for you and for us. Okay. So there are 3 tools, as I said, in the LOCUS family. We're focused on the LOCUS today. They're the adults 18 and over. The CalLOCUS CASI is ages 6 to 18, or EXI is 0 to 5. And I'm just gonna quickly go through till you can read about this at your leisure. So this is part of our slide set if you want to expand these to your world of children. And I know you have a needs assessment that you just were talking about. I don't know, it may be similar to the tools we have in the US, like the CANS and the ANSA. They are, in our view, these are complementary tools. The needs assessment tools give you an organized inventory or list of relevant data points for different need domains. They help you to make sure you're identifying and responding to those needs, but they don't tell you the service intensity required. They just tell you where there are needs. And so you can use these collaboratively or complementarily to both identify needs if that's of value, to identify progress in addressing needs if that's of value. But it's still helpful and, in my view, important to have a separate assessment of service intensity, which is what the LOCUS will provide for you. Okay, I want to get to the end. Just give me a minute, and then we'll have some time for questions. This is background that I want to go through. It's just, so here's the information on the contact, and I mentioned Stephanie Smith-Dillard before, and there's her email address. If you're interested in learning more about the children's tools, there's a contact for that as well. But Stephanie can help you with everything. So you don't, if you just, the answer to all questions, LOCUS family of tools are email Stephanie. You have my email as well on the opening slide. Email both of us and we'll be sure to take care of you. We're a very helpful, welcoming bunch, okay? And we want you to have fun and have a good time. So anyway, thank you. And Laura, Ian, want to go from here?
Thank you, Dr. Minkoff. Wonderful overview of the LOCUS, lots of information to review, and we did get some questions that did come in the chat, so we do have some time to respond to that. So I will ask you those questions, and while we're doing that, I'm going to ask Naveen to launch our feedback poll, just so we can make sure we have time for both. But I will ask the first question. So the first question is, for residential crisis settings, are there any examples of using LOCUS daily to help transition clients to lower intensity services and or discharge?
Yes, I'm not sure what the question means by examples, but the intended use of LOCUS in crisis settings, and that's a good catch because I should have mentioned that, is that the frequency of using the LOCUS for a service intensity assessment depends on the circumstance. So in acute care environments in general, frequent reevaluation using the LOCUS helps you to plan transition accordingly. Whereas if you're doing it for longer term service matching, then you might do it every 3 months, for example. And, you know, and you can do it how often or unoften you want based on what you're doing. So in a residential crisis setting or in a hospital, you might be using the LOCUS on a daily basis to reassess, to determine whether the person continues to meet that level of care, and if not, what level of care would be the next appropriate level to do the transition. One of the specific things that we cover in the training is that when you're doing the variables around things like residential support and functionality and stress, you have to project those assessments based on the environment the person would be in if they weren't with you when you're in a residential setting. So if the person is like safe and secure and non-suicidal because they're in a residential setting, and you say if they go back to their home environment, they're going to be stressed, no support, and they're likely to be involved in risky behavior again. That's how you have to score the LOCUS based on where they would be if they weren't with you. So, but yes, doing the scoring on a daily basis or every other day is exactly what the tool is designed to do. And because it only takes a few minutes, it's simple and it creates a common language. So you can be, hey, our guy, now he's a LOCUS 4, you're a LOCUS 4 service, let's do some transition planning together. And everybody can be on the same page.
Great, thank you, Dr. Minkoff, and thank you, Jennifer, for the question. Our next question is, I would like to get a clarification if the LOCUS will be administered during service initiation only or during intervention or discharge. And I think you spoke to that in your last answer, but I think you can speak to that.
Yeah, that sounds like a question, not to me, because I can't tell you when to administer. You can do all of the above. So it's a little bit like, you know, what I'm hearing is the subtext, is someone in CMHA making us use the LOCUS? And if so, when are we going to have to do it? So the answer is, in it's most helpful if you use it in an ongoing way. If you only do it once for placement in a crisis, if you're the crisis service, for example, and you're using the LOCUS to determine initial response, that's great, better than not using it. But as the previous question addressed, it's helpful to do it again, as the crisis either worsens or resolves, so that you're regularly assessing the person as they're moving quickly through service intensity changes. Because when people are in crisis, they do, and they do quickly. If you're using it to assess ongoing need, you need to do it routinely. Quarterly would be a reasonable frequency, because the expectation is that people will change. Some people may get worse and need more support. Hopefully, most people are getting better. And over time, they may evolve to being able to be more self-managing and not need as much service intensity resource. But it's a good idea to pay attention to it and think about it, because otherwise you get into this idea, well, we placed you here 5 years ago, and that's where you are, and you're chronic, so that's it. And that's exactly not the kind of recovery-oriented thinking that we want. Every individual has capacity for change, hope, growth. And then we also have to be alert to the fact that some people have things happen to them. They get medical issues, dementia, that lead them to have different needs as time goes on. So we have to be paying attention to this LOCUS. Doing the LOCUS on an ongoing basis helps us to pay attention to it.
Thank you for that response. We have another question here asking, is there any research on the average trajectory of LOCUS level of care over time?
So one of the things we're doing, the research that we've done for the most part is on a much shorter time frame level, looking at the face validity, reliability of the tool to do an accurate placement decision. And in order to do the kind of research that you're talking about, and you're stepping into this beautifully, so I'm going to hit it out of the park for CMAHA. We are looking for system data partners with which to evaluate that kind of information. And, which sounds easier than it is, because systems get to be pretty protective of their data. So they don't even like to share it in a non-identifying way, so we can look at these aggregate patterns. And now that, since the federal lawsuit, we've been upping our game to try to figure out how to do this and get resources to do it. So right now in CMHA, for example, you have some organizations that are using it within the broader Canadian Mental Health Association, and then there are other providers that are not CMHA providers that are part of AMHO or whatever. The more that we have a consistent system use that is willing to share non-identified information, the better that we can actually look at that for different populations. One thing I would say, though, you can't answer that question is there one LOCUS frame for everybody? Because everybody's got different starting places. So, we could take a large population and say, for all the people that entered CMHA services all over Ontario or all over Canada, if we wanted, at level 4, what happened to them a year later? That kind of data would be very important. And having this kind of tool more globally used would help collect that kind of information, which would be very valuable. But the level of use is just starting to get that kind of consistency. And then we're still looking for systems that are willing to share their data for that purpose. Yeah. One thing that I will say is that for CMHA as an organization to license the tool is way more cost effective than each individual affiliate doing it on their own. And that would work great for you guys if that's something you want to do. So there. Go ahead, Ian. Sorry. I got carried away.
Great. You're speaking to a lot of very timely topics in Ontario around consistent implementation, consistent language, consistent standardized tools, so that we can look at how is our system doing, and measure apples to apples, and then do some planning with that information. I am going to give a reminder that we'll close the poll in about 30 seconds. We saw that about 60% of you have responded. Thank you so much. So we'll give it another 30 seconds. If you haven't had a chance yet, please do give us feedback. It's important for our offerings that we hear from you what's working and what may not be. And I'm going to go for one more question. And I think I will attempt to answer it because I think it's specific to Ontario, not necessarily to the LOCUS. So Monica asked, will this be rolling out for community mental health, case management, supportive housing? So the LOCUS, this webinar came out of our data literacy series and was one of the tools that our providers are currently using or interested in using. So there is no recommendation or direction from Ontario Health regarding the LOCUS. It was part of our data literacy series of wanting to, we know agencies are using it, are interested in using it, so wanting to provide more information. So I hope that answers your question, Monica. And I would say this is a great conversation to bring back to your senior leadership team around, is LOCUS a tool that makes sense for your agency? I'm going to go to the final slides. So I think we spoke to this. So what's next? So our virtual workshop, this is a two-part series. So on February 23rd from 1:15 to 3:15, Laura has put the registration link for the workshop in the chat. It will be included in the follow-up email we will send out later today. So please do register. Dr. Minkoff, Laura, and myself will be present. We do want to answer any questions you have about the LOCUS. So if you're an agency that's not currently using the LOCUS, please do attend. You can ask any questions you would have about getting started. If you are using the LOCUS and you have data and you want some support around how could you utilize the data, please do let Laura or I know. We could help connect with you before and help think of the questions that we could be offering in the workshop. So please do sign up. If you have any questions about that, please reach out to us. Finally, Dr. Minkoff did talk about how to get connected. So if you have questions about how to start with the tool, individual or group licenses, or other LOCUS questions, Stephanie and Dr. Minkoff's information is on this slide as well. And if you're interested in putting together a user group or a community of practice, let Laura and I know, and we can kind of bring like-minded people together to help leverage each other's knowledge and experience with the LOCUS. And finally, thank you for your time today. We're right at 11. We appreciate all of the great questions. If we didn't get to your questions, I think there was one or two left. We will make sure we get to them at the workshop. So have a great day. And thanks again to Dr. Minkoff for sharing his wisdom all about the LOCUS.